Right, good afternoon to everybody. My name is Jim Chesnutt, and I'm a family medicine, sports medicine physician from Oregon. And I also want to give credit to one of my collaborators, Melissa Novak, who shares the concussion clinic with me at OHSU. And we've put this similar but different presentation on at the National Meeting of American Medical Society of Sports Medicine. And so just want to give her some credit for working the program with me. So you can read my bio later. I'm going to go past that. And I have no real conflicts of interest other than I just want to say we're going to be talking about what's called the impact test, which is a product that we use, and we don't support it at all. I also work with a VA system, and this doesn't represent a VA system at all. So today we'll talk about some of the concussion kind of new guidelines and how we've come about discussing concussion subtyping and how it may impact on the diagnosis and treatment of concussion. And then we'll talk about ways to efficiently conduct a concussion evaluation in clinic. I know that there are different clinics that do that, but our rehab department's integrally involved with concussion rehab. So I hope it's something that everybody will be able to learn potentially how you may be able to incorporate that into your program. We'll provide resources to help care for your patients. So there'll be handouts that we eventually can send to you and you can copy and use them. And then we have some strategies for return to play or some show you some guidelines. And then we'll provide an overview of how the multidisciplinary team works together. First of all, I wanted to highlight that there's this group called the Concussion and Sports Group, that developed these SCAT protocols. They stand for Sport Concussion Assessment Tools. And these have been going on for probably about 20 years now. And about every 4 years, they get together internationally and come up with a new plan. This one was got together in 22 in Amsterdam and then published in 2023. Generally, it's published in the British Journal of Sports Medicine. This is an older version from the Zurich 2012, but look for, this is a great journal that we use all the time that publishes most of the basically standardized protocols for a lot of sports medicine. This is what's called a concussion statement on concussion, the consensus statement on concussion in sport. Again, this is the 6th version, and this is the Amsterdam protocol. And what I'd like you to consider is I have a reference there. You can look this up and read about it, but it does help guide the evaluation on the sidelines and then in the clinic. The sideline evaluation goes through some cognitive testing, some neurologic testing on the sidelines, basically going through various types of assessment, including the Glasgow Coma Scale. Those are not things you're going to use in the clinic, but a lot of times this will be done on the sidelines. What I would encourage you to use in the clinic is the SCOTE, which is new in the 6th version, and it's for sport concussion office-based assessment tool. This is very practically oriented, and our program really mimics what's in there in our clinic, which you'll see. Also, in the United States, we have the Centers for Disease Control, and they put together a TBI program called Heads Up for providers. And this has been around for a long time. 2008, it was first developed and updated in 2021. And it also suggests that there's subtypes of which are physical, cognitive, emotional, and sleep. But it's a program that you can view, and there's a provider course online for this as well. A group of the kind of like the top concussion management teams in the United States got together and put together this program called Team Approach to Treating Concussions in Pittsburgh and published this in Neurosurgery. And they basically said in the red that there's evolving clinical profiles, but research is needed on concussion clinical profiles, and potentially the use of biomarkers may also be helpful. This is a slide from the American Medical Society of Sports Medicine, and it is a little bit busy other than you can see the different petals here highlight different clinical profiles. On the right, we have cognitive, and then fatigue, and then anxiety and mood, then headache and migraine, and then ocular. And those basically are the main subtypes that they suggest, but these are overlapping, and they suggest that more research is need to be due in this area. And finally, I made this on a Mac, so when we look at it here, some of the formatting is off. Sorry about that. The pediatric group got together and they published this in the Clinical Journal of Sports Medicine and suggested that the 7 to 12-year-old group may be slightly different than the 13 on up. And they said that in the 7 to 12-year-old group, it's higher somatic and cognitive symptoms, and those were associated with longer duration of concussion symptoms. And in the older group, there was more severe somatic and vestibular ocular symptoms, and those were also associated with longer symptoms, as well as you'll see, some problems with mood and anxiety. But they also suggested that these subtypes could be used to help focus the assessment and plan. I put up some research that I was involved with just to give you another perspective of how to look at concussions. And if you see down the bottom left there, that's where the injury and the biomechanical injury occurs, that hits different kind of scales of the system in the brain. At the very bottom, there's cellular level, and the cells can be damaged and produce dysfunction that then lead to network dysfunction. But the network can also be damaged by causing some shear forces to axons, so you can get axonal injury as well as cellular injury. And this creates problems that leads to the experiential level, which is what we feel and actually the symptoms that we have. And those symptoms that we have can impact how we interface with the social environment, but also the social environment you're in terms of work and school can actually exacerbate your symptoms. And some of those symptoms may or may not cause, and the symptoms may or not be correlated to increased damage, but certainly cause the symptoms that keep people out of work and out of school and out of sport. And this is another project we worked on looking at like injury on the far left and how it may impact recovery on the far right. And again, this is the cellular network, experiential and social levels. And we narrowed this down to some subtypes based on this work, hoping that we could make some impact somewhere along the way in these causal loop diagrams. And I think if we plugged in different research in these areas, and this is something you can look on online if you like, and under dynamics of concussion.com. So finally, from all this research, we published this concussion guidelines, step 2, evidence for subtype classification. And this was a collaboration with Stanford and Harvard and National Children's, University of Pittsburgh, our OHSU program, and some other programs as well across the country, where we identified subtypes. And these are in the yellow, are essentially the subtypes that we identified. And these are the clusters of symptoms as well, which basically we can have developed programs to address. The ones in the blue are what we call modifiers, which are cervical injury, and a lot of people get a neck injury as well as when they hit their head or have an acceleration, deceleration injury. And most people have sleep problems as well, which is more pervasive. And so we call that a modifier versus a primary problem. And we've been also developing autonomic and auditory subtypes as well. And we'll come back and show this slide a little bit later because it's kind of the basis for how you approach kind of the treatment strategies. So one of our findings was that the most common acute concussion subtypes in adults were cognitive subtype, which is 40%, and then headache and migraine subtype were almost 40% as well, which differed from the children's subtypes, which primarily were headache and migraine subtype, and then the vestibular subtype was 50%. So these kind of subtypes kind of show you maybe where some of the focus of attention should be during the treatment phase. And one other important idea is what are the predictors of clinical recovery? And this is a paper by Iverson and group that looked at and said that those with headaches post-injury had the worst outcomes, but that total symptom report also had strong evidence for worse outcomes. So some say greater than 20 or some say greater than 30 on the symptom score, which we'll show you. And then mental health history, however, was the best predictor of long-term outcome. And so pre-existing mental health issues tend to be exacerbated during and after concussion. So let's move to our OHSU team. As you see here, we have a pretty large group of people working on concussions. On the left, those are my sports medicine colleagues who are physicians, either mostly DOs or MDs, and mostly those are all actually family medicine, sports medicine trained doctors that work on our concussion program. We have a large group of physical therapists, and there is even others working on this, and some people have added in since I made this slide. And then we have neuropsychologists working with us on the right top. We have pain psychologists that work with us in terms of psychology issues. And then occupational therapists work mostly on visual issues, and we'll show you some more about that. Speech therapists work on cognitive therapy, and then we have a very important certified athletic trainer, Ryan Rockwood, who works with us. And then we have lots of other departments work with us, and most notably also pediatric neurology helps us with our headaches. But we're also missing audiologists, even though that's an important part of it. So when we see how the patients come into our clinic, which is sports medicine, they come from the ED, which is emergency medicine, emergency department, athletic trainers, which is ATC, and then sometimes we're actually working on the field and seeing them that way. We get referrals from all sorts of different medical providers, including a lot from chiropractors. And then once we see the patients, then we direct them to the occupational therapists, speech language pathologists, and PTs. And usually that's by about 2 or 3 weeks after the injury, because most people do recover in the first 2 weeks. And if they don't, we really want them in therapy really quickly thereafter. And then if people aren't recovering, then all the providers on the right are other referrals as well. So our clinics, as you can see here, is a little bit different. Just on the right, if you look at it, we have emergency department concussions that are age distribution from the very young to the old. But in our sports medicine department, which is green on the right, you see it clusters around the younger population, although we do see people kind of out to the 60s and 70s. We have had as many as 5,000 patients a year. We have a few less providers now, so we don't see quite as many right now. 60% of them are students in that age group. 25% of our patients we send to rehab services, as it turns out. And now I think it's maybe slightly higher because some of the acuity that we see, but many of the visits are actually in the rehab department. And it's actually, keeps things pretty busy. This is a retrospective analysis that we did from 2017 patients. And so things have gone down just a little bit, but mostly this shows what's going on. And you can see here in our younger population on the left, most of the injuries are sports-related concussions, and there are some others on the right, which is all ages. Most of them, or a higher percentage, are motor vehicle accidents. So we see a lot of motor vehicle accident concussions as well. And so this is what we do in our clinic. I'm going to explain how we run our concussion clinic. And basically, we have an intake for the patient from the medical assistant, which is MA, or the athletic trainer, or the doctor, but we work together. Our athletic trainer goes over the mechanism of injury, goes over risk factors for recovery, talks about current physical activity levels and current status at work and school, among other things. We do a symptom log, which gets input into our electronic medical record. We do use a neurocognitive computerized test periodically, but we mostly access it from the high school that does it at the time of injury. And then we have a neuropsychologist or behavioral health specialist working with us in a treatment clinic that works on sleep, mood, anxiety, and cognitive issues. Some of the testing we do, we'll see, are the SCAT test, which we'll look over, the BEST test, which we showed you, and the VOMS, which I'll go over which is a visual test, visual ocular motor screening, and I'll show that more in depth. And then we give an exercise prescription as well, which is very important. So in our electronic medical record, we have these questions that were queued, and we answer them, and it goes through all the statistics of the injury, whether there was a loss of consciousness, which, by the way, doesn't really cause adverse outcomes unless it's longer than 30 minutes. So usually that's not so much of a factor. And then we go through the history of concussions, history of headaches with insomnia issues, ADHD, and then depression, anxiety, and those are factors that may affect recovery. When they come back for follow-up, then we go through some other issues. Are you back to work or school? What treatments have you found beneficial? Does physical activity make your symptoms worse? And then how much are you sleeping? and also what medications you're taking for concussion. So we have a database that's gone back for about 10 years now that has all this information that we follow. Now, this concussion symptom assessment started out in the SCAT-3 and now all the way up to the SCAT-6. We tend to keep using the SCAT-5 for now because it goes better with our database, but it focuses on symptoms, physical signs, balance impairment, behavioral changes, cognitive impairment, and then sleep-wake issues. And we'll go over these a little bit more in depth, but these are all characterized in the SCAT test. And this is what the SCAT test looks like. The symptom log is the sport concussion symptom inventory. And as you can see, we rate this on full numbers between 0 and 6, with 0 being 0 and 6 being severe. It's not a 10-point scale, just a 6 or a 0 to 6. And then we monitor that over time. And those are, you can look at this later, but those are the basic symptoms that we look at. And of course, they're not all only concussion symptoms, but when you take it all together, this is kind of what encompasses concussion symptoms. And that's most predictive in the first 6 weeks of concussion. The next thing we do is we try to become as objective as possible. And this is what's called the vestibular ocular motor screen. And it is basically looking at different motions of the eyes. So it's looking back and forth, up and down, and then the near point conversion is really important. And the near point conversion is, and we'll show you, is over here. And I'll show you the next slide. So this is a score by which we basically run a person through on the sidelines, which we can have them follow the finger like in an H type, up and down on the sides, across and back, up and down, and look for any vision motion abnormalities. And then we do a near point conversion, which is really kind of one of the more objective kind of measurements, which is, when do you become double vision? And then we keep track of that. When it's over about 6 centimeters, it becomes abnormal, definitely abnormal over 10 centimeters. This is somewhat objective. In the lab, we actually use this method down below, which is more quantitative, which is a see-through eye tracking device. And we use this actually in our studies and watch people's eyes move as they go around a diagram motion. And we've published a lot about how the eyes move relative to the head and how the head moves relative to the trunk over the years. We also use the balance error scoring system. I showed this to you a few minutes ago, and then we basically put a score to this. And for the feet together, the score should be pretty much 0. For the tandem, it can go up to 1 or 2, and for the single leg, it's probably abnormal when it's over 2 or 3. But it's hard. I test professional athletes even in pre-season, and they are very unstable. But of course, they've had lots of injuries. So it also depends on what the musculoskeletal status of the patient. But generally, a score over about 3 becomes abnormal. Now, we've developed a lot of studies using inertial sensors. You see in the center, there's a sensor behind the small of the back, just about L5. And when we apply these sensors, we have a normal patient that has very tight balance, and this is abnormal balance and movement TBI patient. If you use the balance error score system, it's just about 60% sensitive in picking up concussions. And if you use this sensors, it's about 80% sensitive. So using some sort of sensor or instrumented test, you can be much more sensitive. And there's also some force plates and things like that can be useful. The nice thing about these sensors that we have studies where we have people walk around and we can actually know what they're doing in dual task environments as well. So this is a picture of the impact test, and let's just highlight the fact that there's a baseline here. And at a baseline test, you can check and see where they're at before they have concussion. And there's also percentiles, which are helpful. So if you look and see that this was 93 and then a 75th percentile, after the concussion, they had a 66 and a first percentile. So a large decrease in their ability to have verbal memory. And visual memory also decreased in this patient down to less than 1%. Visual motor screen, which is following some diagrams around, and then reaction time also is measured. and then symptom score. So if we just use symptom score, when they get down to 1, you'd say, well, this person's ready to go back to play, maybe here or here. But as you see here, their cognitive test is still less than first percentile. So it is helpful in many instances to use some sort of post-concussive testing in this regard as an additional tool. It's not the only tool we use, and we can return people to play if they're not back to baseline, but it's unusual to do. And we use this as another measure of how are they doing post-concussion. And then whether to screen with imaging. We know that imaging is not safe in children using CT scan, so we try to not use imaging when possible. And this is a great rule. You can look up on your iPhone or whatever and look up the Picard CT rule, and you can go through it. It's just a simple calculation that yes, no answers. And I'm going to show you this here. So if you go through and look at these are the major indicators of potentially a bleed. And if these are positive, then you need a CT scan based on this study. And when you do that CT scan, they have a 4.3% risk of a clinically significant bleed or severe TBI needing intervention. So even when it's positive, they still have a pretty low risk, but it's it's compared to almost zero on this side. So if they don't have these symptoms, but they do have vomiting, loss of consciousness, severe headache, severe mechanism of injury, which is a fall greater than 5 feet or a pretty significant motor vehicle or unhelmeted bike accident, they have a less than 1% chance of having something. And for the most part, all the rest of these can be observed. This person can be observed for a while, for about 2 hours and possibly up to 6 hours, and then they get out of this risk. But these people here, which is 58% of all comers in emergency department, don't need scanning at least. So 60% don't need scanning, and another 30% almost can just be observed, and maybe only 10 to 15% need scanning in an emergency department setting. If they don't have, most people that don't come to the emergency department are over here. This becomes, over here, and that becomes a much higher percentage of people that don't need scanning. So if people come to us later, we never order scanning unless there's a distinct neurologic deficit that would indicate it. If all those are negative, it basically shows that it's 100% sensitive in picking up all problems. So this is a really good kind of like a protocol to go through to limit scanning. So what else do we do when the physician comes in? We just document some things, try to figure out what their worst symptom is, and figure out what treatments they've already tried, and then we modify the treatment plan kind of based on this symptom inventory. But these are the main areas that we look at. So physical symptoms, cognitive issues, emotion and mood, which is a huge issue that needs to be addressed, sleep issues, balance issues, and visual issues. And then there's a physician exam, which you can look at in this article. John Leddy led it, who's one of the leaders in sports medicine, concussions, and it's a practical toolbox. This goes through a whole protocol, which is essentially what we've typed out here. And this is our protocol for our exam. And I'm not going to go through all this other than to say that, we kind of focus it around the head, neck, initially exam there. Then we do a neck exam itself and look for signs of neck injury. And then we do a neurologic exam, which is not different than most neurologic exams you do. We do some coordination tests and movement tests, but then we also do the best test to look for imbalance. And then we do vision testing and also include the tests that we do in the VOMS test. So essentially, it's not a whole lot different than you do for any other neurologic exam. If we identify problems there, we sometimes do scanning, but mostly record that and monitor improvement. We've developed handouts for all these areas, and basically we'll show you those handouts. I'm not going to go over them in depth, but just so you know, they're available and we'll send them to you. And we utilize mental health, in particular, people have symptoms longer than about a month. And certainly over 2 months, everybody tends to get pretty anxious and depressed. And then we'll kind of show you how we utilize the referral system. So for activity, it's very important to consider the fact that, and I'll go over this more, that only after 24 to 48 hours of rest, then we really push people in activity. And I'm going to bring that home in a little bit. So we give this handout to everybody that leaves, and we always recommend exercising after 24 to 48 hours of rest, doing some light aerobic exercise. We talk about sleep, and sleep's critical for healing. And when people sleep, they have growth hormone and other things, and it's really good for resetting and brain healing, of course. So we work on that a lot. And we have this adult and sleep and child version. We talk about headaches. We know that most headaches are migraine-like, so we recommend providers treat them as migraine headaches. And starting out with anti-inflammatories, and usually we recommend Aleve or naproxen sodium over others because it does not cause. There's some studies that shows that naproxen sodium does not cause rebound headaches, as opposed to ibuprofen and Tylenol. And then we have a headache log and things like that that you can use as well. We'll give those handouts to you. But mental health, again, is one of the most important aspects. There is an increased risk of suicide in people that have had traumatic brain injuries and even concussions with multiple concussions. And one of the issues is becoming more isolated, not being a part of the team, not being able to be in school, getting behind in school, and then starting to get bad grades in school. And this can happen to straight A students or whatever, and that because of a high level of stress. So we recommend continuing to work with their primary care doctors, but also cognitive behavioral therapy and getting involved with a mental health specialist who we do what we call warm handout in clinic. Our mental health professional goes in and speaks with people who have high stress and anxiety levels. And education recommendations, we'll go over these in a couple of minutes as well. It's real important because they need assistance early. And if they get the early assistance, they tend to not be as stressed out, and then they actually tend to be able to get back to school a little bit sooner. And there's return to school guidelines, which I'm going to go over again in a minute, more specifically, which is right here. So we developed this statewide program to basically show like when they should not be in school at all. And basically, if they can tolerate more than 30 minutes of cognitive interaction, then they can go to part-time school. And then they could kind of move on to full-time school, but they should be getting accommodations. And this is an accommodations form. And there's specific accommodations here that we check off. And I can provide those to you and go over those more specifically, but just want you to realize there are resources available to help decide what academic accommodations are there. Our speech language pathologists are the ones that do the most in terms of helping with the cognitive rehab and the school accommodations. But so do the physicians. We actually check this off and send it back to the school with the patient. And also work recommendations. I mean, yes, it is a good idea to avoid excessive screen time, but there is not exactly as much evidence that screen time is bad for concussion recovery. But if people have specific visual motion problems or have difficulty with near point conversions, they can have more issues, and those people will need more accommodations than others. For years we've said don't do screen time, but there's the most recent evidence shows it's probably not as significant as we thought it was. And then return to play is, and I'm going to go over this a little more significantly, but return to play needs to be stepwise, and it needs to be kind of monitored, and there's stepwise progression. At the state level, we developed this return to play form to our high school association. And it has areas for documenting the concussion and then a specific return to play. And you can look on this in line, you can grab it if you want. Basically, this is the return to play protocol, which it says, this is actually the updated one now says 24 to 48. And it allows for low intensity physical activity fairly early on. And this even if you have symptoms that have slightly increased, you don't need to worry about it. And then light aerobic activity, sports-specific exercise, then non-contact training, but you have to get full recovery before you go on to full contact practice or anything that would involve hitting head. So light aerobic activity is walking. This is more sprinting and dribbling, and the non-contact activity is going for drills. Now, I want to show you that I worked with the NBA for a while on this, and this is a protocol that you can read through a little bit more in depth later, but basically the protocol is here, which is Stage one is a stationary bike exertion challenge, and this is increase the heart rate of between 70 to 80% of the estimated maximal heart rate for about 30 minutes. So this is pretty much safe in anybody. That there's a test called the Buffalo Concussion Treadmill Test that we know is safe, and this is what this is based on. So once they can pass that, then they go into jogging. So you add 30 minutes of exertion on a treadmill or indoor track, and also repetitive movements of the head and neck, like basketball skills. Target heart rate is still about the same. Stage three, if they can pass it, you do explosive running, jumping, agility drills, and resistance training. And this is to simulate normal basketball playing without any risk of being hit. And then finally, stage four then would be to introduce the cognitive and visual spatial aspects of playing at game speed. So this is actually limited contact, but trying to be careful not to have too much contact. And finally, this is full release. But they also have a baseline retest. We have to do a physical exam to do this. And they also have to have passed the cognitive test as well that is done pre-season and have to be within normal limits of that. And then the return to academic plan is similar, like I mentioned, which is, refer them if need be, if they're not getting better, but really don't need to remove for more than about 2 days from school in general. There's a study of randomized 2 days or 5 days away from school. And the ones that were randomized to 2 days going back to school did as well, if not better, than the ones that stayed up for 5 days. So staying out of school is not required to get better. In fact, may keep them from getting better. And then the return to academic plan is important, like I mentioned. So doubled up on that, but and then we just noticed that in general for the school accommodations, most people get better pretty quickly in 80%. There's only about 5 or 10% that need a little more formalized intervention with the academic accommodations. And then there's a small group that really need a extended recovery. So that's what we see in the pediatric population. So we also have this treatment clinic that is in our clinic that is run by neuropsychology and behavioral health specialists. And it just shows the athletic trainer works on a treadmill test, which I'll talk about. The neuropsychologist works on sleep protocol and behavioral activation. And then the MD and DO just reviews most of this. And then and we kind of have a few of these visits. This is kind of in addition to eventually going to physical therapy, or this is easier access. So we tend to do this first. If they need additional treatment, we incorporate physical therapy, et cetera. In this model, we use different tests to look at their somatization, their anxiety symptoms, their depression symptoms, sleep quality, and we monitor those over time. What we found in here was that the cognitive behavioral interventions were helpful, that missing school was harmful to recovery and anxiety, and different studies have showed that. And so it was really important to do some early activation and early involvement. In our clinic, our athletic trainer also will run through a Buffalo treadmill test, which I'll show you in a minute, which then leads to an exercise prescription. And then he'll work on balance and also work on some of the visual exercises, and which involve kind of near point conversion training, as well as some exhaustion of the vestibular ocular reflex by moving the head back and forth, and then working on neck exercises. So we do this all in our clinic without involving physical therapy if we can, but usually we also involve physical therapy. So again, after about 48 hours of rest, the exercise prescription has been shown to be safe, and exercise testing can be conducted on a treadmill. And this has been done both in initially the college environment, then the high school environment, and we've done it in adults up to age 60 without any adverse effects whatsoever. So we say subsymptom threshold exercise, but and the goal is to be about 80 to 90% of that threshold determined. But the threshold is really when the symptoms increase by 3 on a 10-point scale. So when people say subsymptom exercise, it's really allowing for exacerbation of symptoms by about 2 points. When it goes to 3, that's where you hit your like 100% heart rate threshold, and then we exercise them at this 80 to 85% to 90% up in that range. So, and then you go through increasing the heart rate by 5 to 10 points every 2 weeks. So this is really important to know, because for many years people are told to rest until their symptoms are better. But now the research is very clear, it's very safe, and this is implemented in every university, at least in that I'm aware of, is that we get people back, and we're also doing this with adults and kids. So it's shown to be very safe and an effective way for recovery. And so all these early interventions have been shown to be really helpful, but also to include, like I say, some of the educational and the support groups could be helpful. And so the take-home points from our clinic there is that you get a high acute symptom burden and the presence of sleep dysregulation, and these things prolong recovery. So that's what we're focusing on, is this sleep recovery and trying to figure out how to help with a symptom improvement. So if we can do that sleep improvement, we do it through cognitive behavioral therapy for insomnia, CBTI. You can look that up and implement that as well. And then returning to normal activities sooner than later will actually help with recovery. Again, you remember our areas of the yellow ones, and this is where we recommend our referrals to therapy. So for speech language pathology, they focus on cognitive and executive function issues. And of course, that's all the issues that may keep them from getting back to school or work. Physical therapy works on the balance, vestibular issues, neck issues, but also they also do the Buffalo treadmill test and work on exercise prescription. And then occupational therapists tend to work on visual symptoms and functional therapy. And then the concussion coping clinic are the pain psychologists, and they work to help people through even the PTSD aspects of getting in a car accident, post-traumatic stress disorder. This is kind of another study that showed our kind of how we do our referrals, and most referrals go to physical therapy. There's a slight difference between males and females in this, but occupational therapy is really the second most common and on down. What we also found out that on day 0, it took them oftentimes about 10 days to get to a physician. And after that, it took up to 2 months sometimes to get their first physical therapy visit. And this has become the standard of, not standard of care, the standard care. And this was really sad to see that the first physician visit was here, but the first PT visit was way out here. And there's a big disparity. So we developed a study where we did this intervention of cardiovascular for 15 minutes, cervical for 15, dynamic walking, balancing with moving head back and forth, and then some static balance. And we decided that we were going to implement that at time 0 or wait 6 weeks, which would be standard care. And we did find in this study, and we just published this year, that in people with subacute mild traumatic brain injury, earlier physical therapy improved symptoms at a faster rate than later physical therapy. And this was a randomized controlled trial. This was one we did at OHSU, and like I said, it just got published in Physical Therapy in 2025. So I encourage you to look at this, and you can see the protocol, and this would be the protocol to implement in your physical therapy. It showed, I didn't show the graph for some, but the graph showed that when you started physical therapy, you got better. And if you waited, you tended not to get better until you started physical therapy. The other finding we had here was that if you started the physical therapy later, you tended not to recover as completely as those that started physical therapy later. So it's a really good, important lesson to get started sooner. So I just want to highlight, these are slides that show what our speech language pathologists look at, and you already know a lot of the stuff, but basically they work on cognitive evaluations. They work on all these areas, executive function. But that's looking at the cognitive subtype. Physical therapists tend to look at the neck issues, the vestibular subtype, and the autonomic subtypes. And so balancing coordination exercises and exercise tolerance and exercise stress testing and prescription tend to be the main issue. But they also work on stepwise return to play, which is also exercise tolerance. There's other studies that show that those people that started physical activity within 7 days of acute injury compared with no physical activity were associated with reduced risk of post-concussive syndrome about 1 month. So any physical activity is better than no physical activity, but structured rehabilitation is even better. So at the very minimum, we recommend being involved with physical activity in the first week. And again, this is the Buffalo concussion treadmill test that our physical therapists do. And the goal is to exercise at 85 to 90% of the age predicted maximum heart rate for 20 minutes. But you may have to start out with this 80 to 90% of the heart rate threshold, which is determined on the treadmill test. So again, when their symptoms increase by 10, that's their threshold. So just remember that. It's pretty easy to do. To learn that, has anybody ever done the Buffalo concussion treadmill test? Pretty easy to do. Next time somebody comes, we can go through that. We have people that teach that on a regular basis. And occupational therapists tend to look at the oculomotor deficits. And as you see, 60% of patients with TBI have various oculomotor deficits. So that's a huge number, right? And 90% of those who are symptomatic, we tend to find some oculomotor dysfunction that can be addressed. So it's a very important area to look at. And if people are not getting better, then we often refer to a vision specialist who tends to be a neuro-optometrist. And it's different than an ophthalmologist who's the eye surgeon. This is an optometrist, and they tend to work on visual tracking and visual motion. And then our occupational therapists do a lot of the visual therapy, and but they also work on reaction time and work on these other aspects of eye motion. Also, different areas of sensory integration are focused on as well as driving evaluation. There's a whole protocol for driving evaluation, which I don't think I was talking too much about. And then the auditory issues that have to go along with concussion. Unfortunately, it'd be great if we had audiologists involved, but we don't. We did publish this paper recently about the fact that concussion management guidelines neglect auditory symptoms because we have a Veterans Administration specialty center at OHSU at the VA there. And we found that tinnitus, noise sensitivity, and hearing difficulties were commonly reported, but they often go unnoticed by healthcare professionals. So we're recommending incorporating assessment and rehabilitation of auditory symptoms as part of concussion management as well. And again, these are the three areas that often need to be assessed. And we're now incorporating these a little bit more into our concussion management. And again, a push for if you're going to develop a program, consider involving an auditory specialist. So the take-home pearls here are identify patients you want to see in clinic and set up a triage system for that. We focus on sports medicine, but we also see car accidents. We tend not to see people in our clinic over about 60 because they get other neurologic issues that are challenging to figure out. Our neurologists don't help us out at all, so adult neurologists don't, but our pediatric neurologists help with the headache clinic. So we refer them to, and they actually help manage the headaches. Use standardized concussion intake and assessment form. The SCAT-6 is the way to go. SCAT-6 or the SCOT-6, which I highlighted before. You can use our handouts. We'll send them to you. You can copy them, put your name on them. That's fine. Assemble a clinic-based concussion management team. And if you have a licensed athletic trainer, I would recommend that. But also, this can be done by any well-trained staff. Could be a physical therapist or a sports scientist, a rehab specialist, and neuropsychologist, or a behavioral specialist. And then, the rehab team is really, really important. And we meet together on a monthly basis. We have a journal club, and we also have a separate research meeting because we have a research team as well. And then I guess some other points, early identification of concussion is important. I know that you mentioned that you don't have as many sports concussions. I suspect that they may be either undiagnosed or just not reaching you. They may be seen by the primary cares. I don't really know, but I think it's important to maybe go out and speak with concussion to some of the sports group. Again, the SCOT-6 and SCAT-6 are important. And then just so you know, we have a free coaches and and medical education at this website if you want to look at it. It's kind of interesting. And also the Heads Up program for providers is another great educational tool. We've actually developed at OHSU a course that's called Return to Play Oregon Concussion Education. And we're revising it right now. It should be, I'll let you know when it's available. The new one's not quite available, but it should be available in a month. First one we put together in 2020, there was a new state law that included chiropractors and naturopaths. And so the state legislature asked us to develop a course to ensure that people were exposed to the state laws and all the information necessary to clear people for concussions. Physical therapists in the state of Oregon can clear people for concussions as well as occupational therapists, but not athletic trainers yet, even though that may be coming up. And so these are resources. I encourage you to look at these. These are the resources I used to put this talk together. And they highlight all the issues that we talked about. We can provide more resources as necessary, but is a good way to get started. And that's it. But we basically have been doing this concussion clinic for about nearly 20 years now. So we have a lot of experience, and we're happy to help anybody who wants to think about putting together a clinic like this. And we have we usually have a concussion conference every year. Some of the students that coming over in the past have come to those concussion conferences. And we've kind of decided to kind of hold back on that for a little bit because we've had some change in personnel who are organizing that. But we probably will be having another one of those coming up in the near future. So we can always let you know when that is and maybe align a trip during one of those times as well if needed. And we also have concussion specialty therapist team that could also come here too in the future if needed. So, well, thank you for your time. Happy to answer any questions. And hopefully this is an area I saw that was on your radar for 2026 to 2027, I think. Is that correct? So you got a few years to think about it and let us know how we can be helpful.